Good morning. We're here to continue our discussion on my new book, Prevent, Survive, Thrive, Every Woman's Guide to Optimal Breast Care. And today we're going to talk about one of the most important chapters in the book about getting a second opinion. And this is so important to almost any woman who has either the diagnosis of breast cancer or the diagnosis of a precancerous condition. Now, we know most of the lesions that we remove or biopsy that are completely benign, the pathologist happens to be right about 99% of the time. And for most cases, in the obvious invasive cancers, the pathologists have a high degree of accuracy. But there's a transition zone between normal tissue and breast cancer that is kind of a never-never land. And there's a great deal of disagreement among pathologists, as you'll hear from our story. But today, we're here to talk with Carol Fullman, a friend, a long-term friend, and a patient with a fantastic story that changed my life. It changed our entire approach to a second opinion program, thanks to somebody who really stood up and asked some very important questions. So, Carol, you had some calcifications on your mammogram, and we did a biopsy, and it showed this condition we call atypia that's not exactly cancer, but it's not exactly benign. It's considered a high-risk biopsy. And standard of care is to go out and take more to make sure we're not missing a cancer.
That's
so
correct.
The results came back, and we told you what?
You told me that I was a high risk, there was atypia, hyperplasia, and then I should go on tamoxifen. Well, at the time, I was younger, it was 10, 11 years ago, and I thought, why do I want to go on a drug like that when it's going to change my body, without first finding out a little bit more about it? So I questioned it, and then I called a friend, and his name's Dr. Malcolm Todd, and I talked to Dr. Todd, and I said, look, this is what the findings are. And he suggested I get the core biopsy studies from the pathology lab at St. Joe's and bring it down to Long Beach Memorial. And he wanted to meet with Lowell Rogers, who was part of the Vanderbilt studies on breast cancer.
Very, very famous pathologist, as
He
we'll talk about.
Wonderful. And so he did. He took those studies, Dr. Rogers, went through every slide, and came up with the conclusion that I did not have atypia, right, a little touch of hyperplasia, but he did not see what the other pathologists from St. Joe's saw in their opinion. And it was at that point I came back to you and I said, John, you need to know about this.
Right.
And it became...
I was shocked.
You were shocked. I was too.
Yeah.
Why? I have all the faith in the world in that pathology.
Well, this nails the problem, because we have top flight pathologists trained at some of the top universities in the nation, and so we've had pretty consistency in their reading. And to have a situation like this where it's treated differently based on the interpretation, and this is being interpreted by one of the world's famous pathologists, was extremely upsetting. And the question is, what do you do? And so you played a very important role in that. Can you tell us your story on?
I decided at that time with you, we talked about it, and I said, we have to do something, because obviously there's an error. And so we invited Dr. Page, who is...
Let's take a step back, because we looked at the options and we talked about them, and then you said, well, maybe we'll get Lowell Rogers' original boss who did the original study looking at
Dr. Page.
All these, and you said, well, just get him out here. And I think, well, this guy's one of the busiest pathologists in the world. He's never going to come out here.
That was so funny. He says,
John says, case like this, why
he's
would
never
he do
going
that?
to do that. He's so busy. He is the foremost authority, second, third opinions on breast cancer.
These kinds of lesions particularly.
Absolutely.
Because he did a study 30 years ago where he looked at thousands and thousands of patients that were biopsied and told that they had a high-risk lesion but refused the surgery, and then were followed for 20 years. And what he figured out, really the first to figure out, are what are the specific criteria? Where do you draw the line between normal and starting to get cancer, but just what you had, not atypia, and then the next progression where you have a true risk lesion, which is what we thought you had, and then the next step is non-invasive cancer, and then finally invasive cancer.
That's right.
So he is the guy that literally wrote the book and we refer to. So
and he agreed to come out. He did. He came out, and fortunately he reviewed my biopsies, and he agreed with Dr. Rogers. And then I invited him to my home, along with yourself, the head of St. Joseph's Hospital, Dr. Hines, Tom Hines, he was head of pathology for St. Joseph's, and Dr. Malcolm Todd, who had originally been Nixon's private physician in the White House. Great man, great man. And the one thing that I told everybody when they got there was, my intent was not to profit from this situation. I was not looking to sue. I was looking to make a difference in people's lives who will never know who I am or never care, but I will know I made a difference in the lives of many, many people. And from that point on, I remember standing in the hallway in my home talking to Dr. Page. And I think I have remembered this all these years. He said, when in doubt, in med school, we were taught that when in doubt, go to the worst case scenario. So that means sometimes if they're not sure about the diagnosis, they're going to go to the worst case scenario because that's how they were taught in med school. I get it.
So what this boils down to is that there are many different ways to interpret these, depending on where you've trained. So if you trained in the East Coast under Paul Peter Rosen, you're going to have a very aggressive, what you say, the most aggressive approach. And Dr. Page has kind of a middle road approach, but there are some people that actually miss these things altogether, and there are cases of atypia that they don't call. And so it's been estimated that about 25% of all biopsies done for these in-between or atypia lesions, the diagnosis is changed when people like Dr. Page looks at it. So it's not surprising from your individual case, but was so interesting in your case, Page he had a whole symposium, he invited all the pathologists in Southern California to bring their most difficult slides, and they had a way of projecting them up on the wall, and people had little buttons where they could say whether it was invasive or atypia or hyperplasia, whatever, and then the score would go up on the wall. And Dr. Page was also independently scored, so you could see what Dr. Page called it. And it was all over the map. Every time they must have done 30 slides, and there was no consistency whatsoever. So this presented a real dilemma. I mean, what do we do? Our existing pathologists trained at Stanford, and they had a way of looking at it. And for the most part, it seemed like it worked well, but yours was a case that stood out with a red flag. And so we then, as you just mentioned, have to solve this. And what do you do under these circumstances? And basically, you were smart enough, or we were smart enough to get the head pathologist at your house and discussing it, and then later we discussed it in some detail. And finally we came to the conclusion that what we've got to do is pick somebody's criteria and stick with it. Well, who else are you going to pick? Of course it's Dr. Page. He's the one that started it all. Other people interpret it differently. But the patient gets kind of caught in the middle on this, and we need to have, at least in our program, have consistency. So Dr. Hines, we had Page working with our pathologist for several days, and then we picked Tom Hines to be our dedicated breast pathologist. He went back to Vanderbilt, spent several weeks with them. And then we spent the next year second reading all breast biopsies, anything that was in the transitional area like hyperplasia or atypia or low-grade DCIS. We sent it off to him for a third read. And what we found is for the first couple of months, there was some discordance, there were some we didn't line up. But after about 6 months, we were 100%, and we went for another 6 months. We didn't miss a single one. We finally had been able to adopt these criteria that were developed by Dr. Page. And that would not have been done. It would have been just one of those things had you not said, I want an answer to this. What's going on? How come one of the top hospitals, one of the top breast centers, how did they get it wrong? And you pushed that issue. And what was your thought process?
We ended up doing as I found out later, was that the pathologist who read my particular biopsy, the specialty was ovarian cancer. That's one thing I learned. Another one is that now they do two pathologists will sign off on a biopsy versus one.
Right.
And that's the most important thing.
Right.
As long as you have, that's like getting a second opinion.
Yeah.
But you know what? That's not even enough.
I don't think that is enough, and I think what you bring with the 25% discordance. I mean, there is about a 2% disagreement among
Absolutely.
invasive cancer, but in some of the benign ones actually are a cancer. But for the most part, most of the errors in diagnosis come from these in-between lesions between normal and non-invasive cancer. So I think virtually for anybody, it's easy to get a second opinion. You can just call Vanderbilt. You can call our center, BreastLink. You can call Dr. Lyles in San Francisco. All this stuff is in the book on the chapter, and the links to these centers are there. And I think women should be skeptical, as you were, to make sure, have they been double read? Are they read by breast specialist pathologists? And I think you have to be very concerned or just proactive, and the price of a second opinion is in the range of $150, $200. I don't think it's very much. I don't know the prices, but that's basically what our charges are. And I think it's just worthwhile just to be reassured.
You know, it's not that you're looking, when you go for a second and third opinion, it's not that you're looking for someone to tell you what you want to hear. Mm-hmm. You want to make sure what they tell you is what the original pathologist said, and they agree with it. Mm-hmm. If they don't agree with it, is when you go searching even more.
Yeah.
For me, even though they told me I had atypia with some hyperplasia, I questioned it. Mm-hmm. I do to this day anything.
But you do that, your women's intuition. Now we have there's proof. I mean, the Komen Foundation 10 years ago wrote a white paper saying there's 25% of disagreement among the diagnosis. And more recent publications from the Journal of American Medical Association show we haven't made much progress. So I think any woman that's told she has atypia or hyperplasia should strongly think about getting a second opinion from Vanderbilt or from BreastLink or from one of these places that really specializes in breast pathology.
I would say I wouldn't question it. Just do it.
Well, I think this is really a story that stands out to me. I don't think any of us in our entire career have seen a situation where a single patient found out about a problem and then addressed it aggressively, and then we changed how we perform things, and we've done this for 10 years now based on this new system, and it's worked extremely well. So I remember talking at your house, and Paige was there and saying, well, I've never heard anybody do anything like this, and Paige says, nope, I never have either. So there was totally agreement. This was an unusual and incredible contribution to, as Carol says, the overall health of womankind in the United States.